This is educative video of exoscopic microsurgical management of basilar invagination with atlantoaxial dislocation, reduction, and posterior stabilization. This 40 years lady presented with pain in the neck, restricted neck movements, progressive weakness of all four limbs, confined to wheelchair. Examination showed spastic quadriparesis, unsteadiness of gait, neck tilt towards the right side with bladder bowel dysfunction. With this, she was investigated with MRI scan brain, CT scan cervical spine, flexion extension, and 3D CT angiogram showed evidence of basilar invagination. Left side joint was wider and neck tilted towards the right side, and the atlantoaxial joint was narrowed. These are the images showing the telescoping of the odontoid into the foramina magnum for about 1 inch with a lateral asymmetric rotary dislocation with a tilt towards the right side. These are the images of MRI showing the odontoid going posteriorly, significant pressure on the cervicomedullary junction with the intensity changes in the intramedullary location. The angiogram showed the normal location of both the vertebral arteries, and you can see the C1 arch and C2 dislocation more towards the left side. And she was taken up for surgery. She was put on a traction for 3 days prior, which helps in reduction of the dislocation and basilar invagination. In a prone position, incision was from subocciput C1, C2, C3 exposure, and bilateral C2 ganglion excision, bilateral C1, C2 exposure. This is the position during the surgery with the traction on midline incision, suboccipital incision. The exposure is from the subocciput C1, C2, and C3. Once we expose the subocciput C1, C2, C3, since there is significant compression posteriorly, we prefer to remove the posterior arch of C1 and preserve the bones because we can use them at the later stage for the graft. The posterior arch of C1 is excised widely from joint to joint. During the procedure, we should not touch the dura because already it's a compromised, significantly compressed cervicomedullary junction. We need to avoid touching the dura mater. The soft tissues are released with a sharp dissection. Usually in these cases, there will be fibrous adhesion bands on the dura mater at that juncture, which need to be cut and dura is released. Now you can see the right side and left side. We have exposed the C2 nerve root with the ganglion. We prefer in these cases to dissect these C2 nerve roots and ganglion and cut them because to have a wide exposure of the C1, C2 joints and putting the screw, subsequent stages because of the irritation of the screw, if the root is preserved there, may cause pain in the suboccipital region and neuralgic pain, and there may be difficulty to the patient. So we prefer to dissect the nerve root and excise and expose the C1, C2 joints. That is the C2 nerve root along with the ganglion is divided and cut. During the procedure of this, we come across extensive extradural or extraspinal venous plexus in the way, which causes significant bleeding every step under high illumination and high magnification. We need to understand this and keep coagulating and keep the area very clean so the anatomy is not distorted. Keep coagulating the veins and separating it and expose the lateral C1, C2 joint space. Sharp dissection, cutting the fibrous tissue, cutting the veins after coagulation. The joint space between the C1 and C2 is exposed. Already we have placed the traction, so the joint space gets widened and separated. Once we achieve this, we close this side and go to the right side. The similar procedure is conducted on the right side. The C2 nerve root is exposed and carried distally and the extradural venous plexus is coagulated, and C2 nerve root along with the ganglion is dissected and cut and separated. And as I mentioned to you earlier, always keep achieving the hemostasis and keep the area clean, and extradural venous plexus should be coagulated and the roots are separated, and C1, C2 joint space is exposed. That is the fibrous tissue and extradural veins. You can see the dilated wider veins. Always they are seen at this location. If you don't coagulate, we may end up losing a lot of blood and patient may need a blood transfusion. Little time and meticulous hemostasis will help in preventing this. Now you can see the joint space is widely opened there, and the joint space is prepared. The cartilage and the sinus, the synovial contents of the joint space are removed, and we take out the C2 spinous process and laminae of C2 and spinous process of C3. These are used as the bone graft. Here, the cortical and cancellous bone, which is very good. We don't have to go to the iliac crest and create another incision and painful location to the patient. By preserving these bones from C1, C2, and C3, we can have enough bone graft material for these cases and prevent one more incision. Now the cartilage and the synovial membrane from the right side, C1, C2 joint space is taken out. Here, the joint space between C1 and C2 is narrower because of the tilt asymmetric dislocation, where we need to put more grafts into the right side so that this is elevated, and this helps in correction and prevention and achieving the normal location of the cervical spine, and this helps in correcting the torticollis. Some authors use the spacers, and with the bone graft, we prefer to use the bone graft, which is of more helpful in causing the fusion subsequently and immobile fusion. Once that is done, the inferior facet joint midline, we drill the C1 lateral mass directed superiorly and medially, and the drilling should be quite deep so that you don't have to use the tap. 22 millimeter self-tapping screw is selected depending on the preoperative CT scan measurements to insert, and very easily and nicely the screw goes inside the C1 lateral mass. There may be some amount of bleeding from the site of the screw insertion. You can stop it by using the surgical. Now we go on to the left side. Again, the joint space C1, C2 is prepared. Now I want you to see the wider joint space on the left side. You can see there because of the asymmetric tilt, and the C1, C2 on the left side is quite wide. And here again, we need to use more bone graft to this, and the bone graft taken out from C1, C2 and C3, and laminae posterior arch of C1 and lamina of C2 are used, and the graft is placed and joint is fused. Once that is done, similar procedure again we conduct. With a 1 millimeter diamond drill, the inferior part of the lateral mass of the facet joint, central part, is drilled 15 degrees medially and superiorly. That is a correct the direction where we enter the lateral mass of the C1 arch. This fact needs to be kept in mind, and we drill quite deeper. If the drilling is good, you don't have to use the tap in these cases. Again, 22 millimeters self-tapping screw is inserted and put on the X-ray or fluoroscopic control on as both the sides. Again, there may be some amount of bleeding from the site, and where we have inserted the screw, it is controlled with the Surgicel and the bone wax. Now coming down to C2, we put a pedicle screw in the C2. Central part of the lateral mass is selected, and the drilling is done anteriorly and slightly medially about 10 degrees, entering the body of the C2 vertebra, again under fluoroscopic control. And 24 size, that is 24 millimeter 2.4 centimeter screw is selected and inserted. Similar procedure is done onto the right side. Again, central part of the pedicle and lateral mass, and drilling is done anteriorly and slightly medially about 10 degrees, enter the body of the vertebra under fluoroscopic control. Again, the screw is inserted, 24 millimeters 2.5 centimeters size screw is inserted upon the C2 on both sides. Now the screw insertion is done. There may be some bleeding from the site of the screw insertion. You can control it with the Surgicel or the bone wax. Next, the connecting rods are measured with the malleable measuring rod, and the rod is prepared. Usually we prefer 1 millimeter superiorly, 1 millimeter inferiorly in these cases, not to extend more than that. The screws are placed, both the screw heads, and the rod is stabilized as shown here. We prefer to use the same length anteriorly and posteriorly. I want you to see how loose the C2 is and moving during our insertion of the screws. Once that is done, the screw head needs to be tightened. At that time, we use the screw head stabilizer so that screw doesn't move when we are tightening it and doesn't cause loosening of the screw inside the lateral masses of C1 and C2. Similar procedure is done on the left side. Again, measure length of the rod is taken, keeping 1 millimeter anteriorly, superiorly, 1 millimeter inferiorly. The screws are placed and the rod is fixed, and the screw heads are tightened using the screw head stabilizer. This is the lower part of the screw, and again these are done under high illumination and high magnification without causing the mobility during the insertion of the screws. The screw head stabilizer is brought in and screw is tightened, and both superior and inferior screws are tightened as shown here. And you see the screws here inside the bodies are going to be very delicate, so mobility during the tightening needs to be prevented. Now the duramat is well exposed. We prefer to drill the foramina magnum, posterior rim of the foramina magnum, make it raw. The cortical bone is exposed so that we can put a graft between the foramina magnum and C2 laminae to achieve posterior bony fusion in these cases. Now we take off the part of the laminae of C2 and we can use it as a graft. Now you can see the mobility of C2 has reduced and the laminae is taken out, and C2 dura mater and the cord is decompressed because the MRI shows the still significant pressure on the C2. Now the bone is taken out. We prefer to put a thick gel foam on the dura and spread the bone fragments from foramina magnum up to C2 and cover them with the gel foam so that they don't get dislodged and help in posterior stabilization subsequently. This is the posteriorly placed bone grafts along with lateral mass bone graft fusion with C1, C2 lateral mass fusion with the implants. The muscles are closed in 3 layers of the drain. This is her post-operative status. We continue the traction for 3 days, and post-operatively she recovered very well, power came to 5/5. Breathing is normal and she is taking oral. After 3 days, the traction is removed and Philadelphia collar is input. This is her status on day 6. Deficits improved. She was on wheelchair. Now she is walking. Power is 5 by 5. Neck has become straight. The torticollis has disappeared. These are the 3D CT reconstructions of the screw placements in both the sides, right side, left side, and in the center. This is our neuroanesthesia team, treating physician, neuro rehab team. Our presence online with more than 630 microsurgical, endoscopic, exoscopic navigation guided, educative neurosurgical operative procedural videos on our YouTube neurosurgery educative video atlas. Thank you very much for viewing.